and welcome back to Health Watch. We've been talking to Dr. Ray Dragan about wrist injuries, and as we looked at it, you were describing some of the fixation devices that we have now for the wrist. And I have to admit, I'm kind of amazed because we think about doing bones and the long bones, particularly the femur, older people that fall and they have fractures of the hips and the like, and we pin them and do all kinds of stuff. But I think the wrist is just a fascinating area because it's such small bones that you work with, and I can see that the devices have been commensurate with that. So go ahead, you were trying to show us what the new ones were.
And most of the people who come in when they broke the wrist think, well, I'm going to get a cast.
Yeah,
and
absolutely.
They're often pretty surprised when I tell them that they really should have surgery. But again, we've shifted more towards surgical treatment for these distal radius fractures because of this new technology.
And just one question, Ray. We talked a little bit about the break. Is that dependent on the age of the patient?
It is. We see these type of fractures in all age groups. In children, most of the time, these are treated non-surgically. Okay. But as the patients get older and the bone gets softer and tends to crush more, then that's where surgery seems to be a lot more beneficial.
Okay.
Because we can really realign the bone more anatomically now than anything else that we have done in the past. So this is an example of one of the plates that we use. There are multiple manufacturers who have these, but this is made specifically for the radius, and this particular one is for a left radius. They come in left and right, and these little pieces sticking out of the plate are guides so that we can drill through, so that we can get our drill holes perfectly straight, so that the threads in the screw will lock directly into the plate. And once we put those in, then it looks something like that. And this is another version of a plate. This one is titanium, this is a stainless steel. But you can see that there are a lot of screws that go in there. And the way this works differently is that it doesn't have to go through the bone on the other side. First of all, if you put the plate in and the screws stick out too far through the other side, they're going to rub against the tendons and potentially could cause a rupture of the tendons. Sure. So with this technology, we don't have to put the screws all the way through the bone, and then we don't have to worry about those tendon damage. Basically what these do, they just prop the pieces of bone up and support them without having to really screw into them. In fact, a lot of these are just smooth pins. So it's very interesting how it works, but it's very effective. When we do the surgery, it's done through an incision about 3 inches long on the bottom of the wrist. Typically takes about 45 minutes or so to do the surgery, and it's done as an outpatient, so the patients are going home that day. We see them back a week and a half later, get the stitches out, and then we put them in a carpal tunnel brace, just a small Velcro wrist brace. They don't need to be casted. We'll start early range of motion at that time. We'll just have them start to work the wrist up and down and rotate it a little bit. And by 4 weeks after surgery, we take them out of the brace and increase their exercise program therapy at that point. So I find that these patients have done very well with this surgery. We're operating on patients that are a lot older than we ever thought we'd be doing.
Really?
And a lot of patients will come in and they'll say, well, I don't really want surgery for that. But then they come back and their wrist is crooked and they look at it and they say they really aren't very happy with that.
Yeah.
So now they're coming back and they're really pretty happy. Their function's good, and I think even, considerably older patients are pleased with the results.
You talked about the obviously hardware. Do you take the hardware out, or does it stay in there?
Rarely. These are made specifically so that they fit flush against the bone, and that way they don't rub against the tendons, and it rarely needs to be removed.
Really? So they stay in there permanently. And the function, I guess it's all about, particularly with the wrist, it's all about the fine functions. When you think about what you use your wrist for in any one day, it's a lot more fine functions than even, say, a hip or the like.
Right.
Right. You talked about fractures, but what other kind of non-fracturous injuries do you see in the wrist, and what can you do about it now? I mean, the wrist is a delicate joint.
Well, could we talk about one more fracture?
Do it. Hey, your show.
There's one other bone that I'd just like to address called the scaphoid. And that also, that's one of the carpal bones. It's right here, down towards the lower part of the thumb. And that is a common injury in younger patients. It also occurs almost the same mechanism, the fall in the outstretched hand, but oftentimes instead of breaking the radius, the scaphoid is fractured. And sometimes the x-ray is obvious, and those patients then seek treatment, but sometimes this fracture is not really visible on x-ray and can cause a lot of problems. It's a difficult bone because it's slow to heal. It typically takes twice as long as a distal radius to heal, and frequently doesn't heal. Even with proper treatment, sometimes it doesn't heal, or sometimes a portion of the bone will die because the blood supply has been interrupted as a result of the fracture. So this is a bone that we very frequently operate on. Even now, if it's a non-displaced fracture, you can certainly treat it with a cast, but we find that by operating on it and putting a screw into the bone across the fracture and compressing that fracture together, that the healing time is cut in half, and typically will heal in about 6 weeks. There's even a technique to do this percutaneously so that you hardly have to make much of an incision at all. What we use is a screw that that's very small. It's a 3 millimeter screw. There again are a lot of manufacturers of this device and variations, but basically what we do is insert a guide pin into the bone, and then we pass this screw over top of it and advance it into the bone. It compresses the fracture nicely. I can show you on a model if we have time later.
Okay.
How we do that. That has been a huge progress with scaphoid fractures as far as percutaneous treatment.
Yeah, I'm just amazed because like I say, having been around medicine all my life, just to have what we're doing with wrist now that you wouldn't have thought you could have done before, and the advancement in technology, and it's all about function. How many of these are? And occasionally you'll get cases like this where you get undetected fractures and the like. Maybe sometimes they're difficult to see. The use of MRI and as your diagnostic tool in making sure some of these.
Yes, MRI is very helpful for diagnosing fractures that are not seen on x-ray. Unfortunately, MRI is not as helpful for many of the other wrist problems. The structures are so small that even MRI can't pick up small cartilage defects or some of these small ligament tears. So it's very important to make sure that even if the x-ray is negative, that the patient continues to follow up with their doctor to pursue this further and maybe get an MRI scan done, or another possibility for persistent wrist pain is to do an arthroscopy of the wrist.
We got to take a break, and I want to come back and talk about that diagnostic technique and some other issues, and we'll be right back after this message.